Well, good morning. Happy holidays to all. I am in an interesting, different environment this morning for those of you over on Facebook Live there. I've got Zoom going over here. I am repurposing a spare room since we still got guests in town. I'm looking forward to spending my last moments with those guys before my son goes back to med school. Um, I am also using a piece of different gadgetry I just picked up for myself for the holiday. It's a opal tadpole um, camera for my computer here. So wanted to try to get these a little better quality on the video. Not that you need to see my scraggly ass face any better, but at least it'll look a little more professional, maybe. Let's see, we've got items to catch up on. It is the 30th of January, the night before New Year's Eve. And I have had a lovely week with my family here. My son's been in town with his girlfriend, and we've been burning it a little bit at both ends, having a little later evenings and a little more drink, and it's been absolutely delightful all the way around. But I can feel my wicks burning at both ends. Let's see. Glenn Harris may show up on here, hopefully at some point, in one of these venues to talk a little bit about his upcoming program. The Disc Dynasty, it's a celebration of the Mixture and Bar 1934 paper on disc herniation. And I was pleased to be included in that virtual presentation. Stu McGill is going to be there. James Cox is going to be on there. And I don't know how in the hell I wound up getting included in that kind of company, but I certainly do treasure that, as those are a couple of icons in my work. Let's see. Business wise, those of you over here on Facebook Live can show up or can go to the link that is on your phone there, and you can find that links to the online academy where these folks over here on Zoom already are. That online academy will give you access to 35 hours of continuing education online. And there's periodically we open up the lifetime membership. You pay one time, you get the service for life. As we continue to add materials on there, it'll be absolutely no extra cost to you. Also, when you are in the online academy as a lifetime member, you'll get $100 off of our in-person courses. I say our, it's just me now. It's Dr. Justin Dean has decided to move on to pursue other things. So I will be teaching those in-person courses and taking the helm of this interesting neurocentric approach extravaganza that we are working on. The online or the in-person courses, the first one that we've got scheduled is February 10th and 11th. That is going to be in Seattle, thanks to Doctors Kelly Henry and Carly Causey, former UWS R2P folk. for hosting me there at Seattle Chiropractic and Rehabilitation and Sports Chiropractic and Rehabilitation. And that will be coming up. That'll be a lower quarter course. Several of you have already signed up for that, and I look forward to meeting and playing with you in person. That's going to be a fun gig. Let's see, this week may be a wee bit shorter, owing to the holiday and the fact that I'd like to go spend some time with my family and perhaps yours. And I had a bit of a short work week this week, so I've got a few updates on some of the cases that we've talked about before. But we could also pivot a bit and turn the camera, so to speak, on all of you guys out there. If you've got any questions or comments, feel free to drop them in. I can try to get to them over here on the Facebook link. It's a little more difficult there for me to juggle both of those. But if you're over here on Zoom, it's easy for me to for you to see what you've dropped into chat as questions, and then we can respond to those. So if you do have any questions, don't hesitate to put those up, and I will keep the chat open here so that I can see those as they pop up. Okie doke. All right. So the cases that let's repeat some of the ones that have, or go back and revisit some of the ones that we've talked about. Some of you might recall I had a retired Marine with a functionally unstable, possibly anatomically unstable lumbar segment. He was, I believe, in retrospect, I think he was 19 years status post, a 3-level lumbar fracture in a motorcycle collision, and was suffering from intermittent incontinence. The incontinence was poorly evaluated over the last 5-6 years or so. He was not in a surgical kind of situation, according to the previous docs that he'd seen, and he didn't want to undergo surgery. And he had found that basically by avoiding certain movements, mostly any that involved lifting his left knee a little bit higher, then he would lifting his left knee higher, and especially if he did that and then tried to externally rotate the femur to step up or around something on a job site where he works in construction, then he would have a very sketchy moment whereby he could find himself both bowel and bladder incontinent for a short period. Difficult way for a previously very athletic individual to get through life. We basically have been playing a DNS card with him, trying to improve his stabilization strategies, working on improving his anterior oblique kinetic chain function. I have used some of the things that some of us have learned from Dre Spina's work with FRC, some of Guido Rissinghem's tactics as well. Things that involve what looks like trying to kinetically activate his stabilization strategy across the torso prior to doing that movement that was provocative. So we try in that circumstance to line the movement dominoes up consciously so that he can perform a cognitive override of the movement and stabilize first very consciously before he starts to initiate movement with the leg. Now, my working premise is that when he tries is that the lumbar segment, which is unstable, when he tries to activate the left leg into hip flexion, the psoas is activating on that segment in such a way to present threat to that particular area, and that is what causes the symptoms that he was observing. And when we slowed him down on those movements, we had a lot of luck with that. And the way that we slowed him down, I started by using the DNS principles, by putting him on his back in supine position, working a 3.5-month position, and testing the waters. We did that very carefully for the first visit. Then we progressed that by using wall bug, using hands for stabilization on the wall, making the surface underneath a bit less stable so that it would challenge his ability to react to his environment a little bit better. And then I stood him up. And on standing him up, we start with just fingers on the ASISs, thumbs on the rib angles, and trying to keep an equal distance between those fingers as he slowly flexes each hip, raising the hip. And then we sped that up a bit, put his hands on the wall, and started working through more complex gait patterns. So then I would have him walk with a marching type step. And what I try to do in those circumstances is to go back and tease out from the history a prior movement vocabulary that he already has some proficiency in. So we're going back into places in his somatosensory cortex where he's already got some linkage that I might be able to reintroduce some movements in a slightly different way and get some better buy-in. I found out that he previously was very much enjoyed baseball. He used to pitch. There's a cross-body anterior oblique kinetic chain dominant movement that I can exploit. He had previously participated in Muay Thai, and as a martial art that involved often with closed chain positions with the hand on the back of the neck in a clinch with a more explosive hip flexion kind of moment. So we have played with exploiting that. And within his martial arts training and even some of his military training, worked with like low creeping types of movements, almost reminiscent of capoeira, playing into that. And I've been very pleased at how he has responded to that. We had a setback. The only setback really that we've had was when I tried to take his 3.5-month position to I melded into gymnastics types movements and put him in a hollow body position on his back and then stood him up and put him in a hollow body position hanging from a bar. And that traction on the bar when he let his lumbar spine go was sufficient enough to aggravate that unstable segment. That was 2 weeks ago. So last week when I saw him, what I attempted to do was to put him in that same position, but to bridge up to it by doing single leg movements with the support underneath him to start. So basically started marching in a hands overhead position with hands on the bar, and then slowly bent the knees to slowly add that hanging position. But I didn't want him to allow that lumbar segment that was reacting to this to fully go to tension. I wanted him to maintain some conscious control over that area. And playing that way, we had a very good response. And I was able to get him to hang and alternately do knees to chest unilaterally without aggravating his back too much. So that was one of the cases that we did. And He is coming along quite nicely. Now, when we get down in a creeping position on the runway in our gym, he can go through a creeping kind of, almost like a boxing approach where you get down and duck under and take marching steps and step out, step forward and out, and then do a retreat, stepping back and so forth. And he can throw now. We play catch with a ball in the gym, and you get the smiles on the face and the hope, and all of that stuff starts to factor back in. So I'm very pleased with the way that case is going, and I'll keep you guys abreast of it. Questions out there about that case? Okay. Not seeing anything there. And another follow-up on a case I saw a few weeks ago from the veterinarian. That was a top-down case. These cases, by the way, those of you that are um, in either you're not a member over here, or you are a member over here, and you want to catch up on those, you know that I'm recording these. I put them up on my YouTube channel, and then I typically am importing that into the blog on the NeuroCentric Approach site. So if you are wanting to watch these or review any of this later, you certainly can do that there. But one of those cases that I parked there on the blog was a top-down case of a woman that was a veterinarian, and it was the SI joint issue. She had was positive 5/5 on Laslet's tests. So I knew I had a hot SI joint. I just didn't completely know why. And she'd had a prior poor outcome working with another chiropractor who had manipulated her SI joint. She had constitutional hypermobility as well, Beighton index 7/9, as I recall. And she had a whole lot of overlay with life circumstances going on. A husband who was dealing with alcoholism, couple of kids that were having a difficult time in the pandemic, etc. We actually had almost panic attack occur in our last encounter. And it occurred when I was exploring a side posture, not manipulation, but it resembled the manipulation position that the previous chiropractor had used. And I was using it to do dermal traction method and transverse nerve mobilization of the middle and superior cluneal nerves to see if we could get any effect there. And when I put her inside posture and put hands on her there, we had a frank conversation before and an agreement that if she experienced any upregulation, she felt like she was, in a position she didn't feel comfortable with, then please be, upfront with me and let me know. And I could see she was getting a bit sympathetically upregulated. So I checked in with her and said, "Hey, how you doing right now?" And she's like, "I'm really having a tough time." So I took my hands off of her and I asked if she was okay. And I asked her if there was anything that I could do to help out. And to her credit, she was able to identify where she was working through her situation at that particular moment and say, I think I'll be okay if we just go slow and you tell me what you're doing and why. And I'm like, that's great. So, I reinforced her for that. And there, you guys that have done your motivational interviewing techniques, we're working off of step step one in that process to think about validating the person's experience, and then to ask permission for and to be very clear about what your intentions are in those particular circumstances. We work with some breathing exercises, 4 seconds on the inhale, 6 seconds on the exhale, calm her down. I asked for permission to put my hands back on her, and she gave me permission, and then we worked from that particular angle. And we were fortunate as well to get some buy-in after working with the cluneal neurology. I was happy about that, but I still don't know why she had positive 5 out of 5 on the Laslet test. If it was positive 2 out of 5 on the Laslet's test, and those two happen to be the thigh thrust and the sacral thrust, both which involve direct contact over the middle cluneal nerves as well as the SI joint. If it was only positive on those two, then the cluneal nerves are still in my main thinking there. And if it's not, then and we've got all 5 positive like that, which is quite unusual in my world, then I'm looking at, a hot SI joint, and I got to figure out why. So she was sent over originally by her naturopath, and I contacted the naturopath with her permission and requested at her upcoming visit with the naturopath an arthritis panel, get a C-reactive protein, possibly an HSCRP, anti-nuclear antibody test, rheumatoid factor, and a HLA-B27 to make sure that we're in good stead there and don't have a sacroiliitis that is going on. So there's that case and a bit of follow-up on it. Dr. Jerome Fryer of Dynamic Disc Designs is joining us here on Zoom. He's dropped a question in the chat. And Jerome, if you've got your ears on there, I'm happy to dialogue with you on this too if I see you come back on camera. But Jerome leaves a question here. What clinical clues do you look for to exclude spinal manipulation as part of treatment? I find I work, this is a really good question, and I think I'm hoping that Glenn Harris will be able to get Jeff Hebert to come on to that event. He was asking for some recommendations on somebody to address specifically that question, Jerome, on a lot of our intakes. How do we decide as chiros to when manipulation is more appropriate, or when it's contraindicated? And I suggested Jeff Hebert. Some of you might know his name. Jeff is a PhD, DC. He was at University of Utah. I'm not sure where Jeff is these days, but he was co-author on a paper with Julie Fritz, and I'm forgetting her first name, last name DeLitto. And these are papers that years ago Stu McGill turned me on to as well. But they did some nice papers on manipulation therapy and how to it was a clinical prediction rule, as I recall. And I kind of follow that sort of rubric, Jerome. And so in general, if I see instability that is high on my suspicion list, either from acute trauma or from constitutional hypermobility, pregnancy, I definitely see less value in manipulation. I see a lot less value in the acute lumbar disc. Professionally, I think the cost benefit analysis there is a bit on the high side for me when I feel like I can get very similar responses for moving more slowly with a grade 3 or grade 4 mobilization technique and keep threat levels relatively low. And then if I am on the fence about manipulation, then I'll do a trial setup and work through grade 3 and grade 4 mobilizations per Maitland. And if it's well tolerated and then I have the patient's permission, then I'll move into it. I don't willy-nilly just lay people down and, start whacking and cracking. It's not my style. And indeed, I get a lot of referrals that of people that have been subjected to that kind of treatment in the past, and it didn't go so well. And then subsequently, primary care physician or naturopath or some other professional refers over to me. Do you have any comments on that, Jerome? You're welcome to jump in here. And I saw you getting a model set up there as well. Do you have something to share?
Hello, Phil. No, not necessarily. I don't have anything to share. I was just kind of, similarly, I do also, I think it's probably a good portion of us that do get patients that have had some form of manipulation, and either it's been, short-term relief, but not prolonged results, or even, to the point where, it exacerbated symptoms for quite, for a number of days or even longer. So I just find it interesting, and it's often the case for me. It's like, okay, which patient gets manipulation as part of the treatment plan, and which you're not going to respond as favorably. Yeah, I'm at the, in the same camp as you. If you're suspecting hypermobility or instability, but one of the things that I find, I guess for the most part, we want to make sure that, patients are getting a symptomatic outcome as a result of treatment. But if someone is self-manipulating, I think it's reasonably safe to manipulate, because they're not, if they do self-manipulation on the regular, you're probably not looking at an adverse outcome, because they're already familiar with that. They may be just thinking, okay, I'm not getting the right manipulation. So when I hear that in the history, it's usually safe to go looking for levels that potentially they are not getting at, an adjacent segment or adjacent region. And then I instruct them on, okay, maybe, you don't want to do, self-manipulate, 10 times a day. That's not apparently, that's obviously not helping you. But you can kind of, lead that into the conversation of, segmental instability, hypermobility, however you want to reference it. But anyways, I'm always looking at, first do no harm, right? That's kind of, it's in the oath. And if we can kind of pick up on things. So I just wanted to point out, if somebody is self-manipulating already, it's probably going to be okay if you go in there and try to mobilize an adjacent segment. You're probably not going to get, somebody to flare up. So that's all I wanted to share. That's kind of some of the clues that I pick up. And obviously with that case that you were talking about, I think it was the veterinarian there that, had trauma as a result of what happened there. Well, obviously you've got to, you got to coach that through the clinical encounter, that, we're not going to do that again, straight up right out of the gates, right? Because that's not going to be a great outcome. and another point too is, we tend to think that we're manipulating SIs, but, 5-1's getting a whole lot of torque there, right? In the process. So, anyways, just, thought to share a few things there, Phil. That's all.
Thanks, Jerome. I appreciate that. Yeah, and I agree that we go the first do no harm. That's probably the first question right there. Would this be harmful to the patient? But then right on the heels of that, as well as this, is this the right tool for the job? And then working at it from that standpoint. Mark, I suppose you probably got some input here as well, because your low force kind of methodology will be a really good input on this kind of stuff and a good option for a patient.
So in relation to that, I appreciate everything that you said and that Jerome said. And I've been very fortunate to do fairly extensive studying with the osteopaths who primarily use what they have a bunch of techniques they use, but one of them is what they call muscle energy, which, if you gave it a generic name, it would be post isometric relaxation applied to stuck joints. And I really like that approach. And then there's a subset of patients, I don't know that you really call it manipulation, but strain counterstrain from Jones is a slacking technique, the opposite of stretching something. And for the patients that it works for, it's rather amazing. And I have a little handout on that where I explain the principle and maybe make a video for them of what I did, finding a position where I move them into something that creates ease and way less tenderness. And you just hold that for 120 seconds. And those are two of my favorite very low force manipulation techniques that are quite well tolerated. And so I just think that's a useful thing. And the SI case you showed, true SI pain, besides the Laslet cluster, it's likely to have multiple. If it's a female, it's going to be someone who's multiparous, because those hormones create ligamentous laxity and, of course, trauma. So, it's useful to rule out people who move too much in the first place. And I love what Jerome said about self-manipulation, because it's like, if you self-manipulate, like Jerome said, it's likely that the pop is happening above or below where the problem really is. So that's, anyway, enough said from me. Thank you.
No, that's a good point. And I was going to ask of the osteopaths that you speak of there, who you're referencing in that regard. And it sounds like Jones and who have you played with directly with the PIR or crack? It seems like
So
we get a new acronym on that about every 5-6 years. There's a new doc that comes along. Dre Spina puts a term on that, but I learned it as you did, as muscle energy technique, aka, pardon another acronym, PIR, post isometric relaxation, aka some would suggest even positional release is another possibility there, and then CRAC, CRAC, contract, relax, agonist, contract. So yeah, I think we're all kind of looking at that same agonist, antagonist reflex arc that we're playing with. And I think Jones is probably dealing with a threat-based mechanism of just put a person that is on upregulation from unperceived, consciously unperceived uh, threat exposure, and reducing that threat with so-called slacking techniques, as you refer to, maybe that's what we're observing with the Jones strain counter strain. I don't know. What are your thoughts there, Mark?
Um, I've been doing this for 43 years, and about 8 years into my career, I was first exposed to the osteopathic world. So it's been multiple different teachers. There was an osteopath up in Seattle who taught chiropractors, PTs, massage therapists, the muscle energy stuff. The original work is from Fred Mitchell. He wrote the text on muscle energy. Um, and then I had this wonderful period of exposure to the French osteopaths, particularly Jean-Pierre Barral,
Right.
where I learned to mobilize the visceral organs. And whether I buy all of the theories or not, I find that assessing the front of the body for fascial restrictions seems to be very important in a subset of cases. So that's a brief synopsis. So
Yeah, I
there was
think
one particular guy. Oh God, I'm spacing his name, but it was Mark Bookout. He was a PT, and what I liked about what he did is he would find whatever the restriction was, do muscle energy on it, and then show the person a low force self mobilization that they could do as a home follow up. So he was teaching them to mobilize their own clinically restricted segments, and makes me think about in the old days, chiropractors used to build travel cards. A travel card was a list of where that person typically needed adjusting. Well, okay, if they have typical places, let's show them how to mobilize those places. So,
yeah. And again, if we're playing the NCAA game here, I would heartily encourage as well investigating more deeply, both from a functional perspective and also from a threat perspective, why those particular movement patterns seem to dominate, and then inform the patient in regards to that, and give them self-efficacy or self-efficacious things that they could do. I think the Baral work might even have been, Mark, in our original encounters. We were at oh Jesus, his name just went right out of my head. The tensegrity therapy
you're
course.
talking about George Roth tensegrity,
George Roth, yes.
and that was a takeoff on not Baral's work, but a different French osteopath who had a very complex system, but ended up doing something similar to what George Roth did. And I can't even remember his name anymore, the original French osteopath.
A lot of Roth's work, as I recall, was based on that Donald Ingber, Ingber, who Ingber did some of the first mechanotransduction papers on movement of fibroblasts in regards to mechanical stress on the system. And I recall, and his papers were published in Scientific American like 1995-ish. And that was kind of fascinating because they put a culture of, I believe it was latex, in a petri dish, and then put fibroblasts in there and exposed it to different kinds of physical force based on positioning, and then watched how the fibroblasts reorganize themselves in response to the mechanical stress. I'm sorry, I'm not dying over here. Can somebody give me a Heimlich, please? A little help. But
that wasn't that the tensegrity model, and we had these little models, and you showed you pull on one thing and everything else moves. And
exactly, it's a buckyball. We all had our buckyballs that we play with, from Buckminster Fuller.
And then what chiropractors and what George Roth and various people did is extrapolate from that and say, if this, then that, which is not necessarily science. It's just what humans do, try to make sense of things, you know? So,
yeah, frustratingly, it seems how most of us in Cairo world have historically gone, but there's, I would also say, you know, and I won't say in defense of that, but there are a lot of market forces that have been at play on the profession over years as well that have kind of driven the profession into various directions, you know, just for pure survivability. Um, and I think that when you don't have a research venue that is set up in a way that you can explore some of these things from a legitimate scientific perspective, then you're left with anecdote, and that is kind of the way that many of us unfortunately had to conduct ourselves out there. And then around the time that I came out of school 20 years ago, we were just then, because I guess Sackett didn't come up with the whole idea of evidence-based medicine until I believe around 1995 as well. We were just then starting to get exposed to the scientist practitioner model and learning how to do case studies and case series designs and things of that sort, and being encouraged to do that kind of stuff at the very lowest level of generation of legitimate scientific information in order to build a bridge up to something that looked like a randomized controlled trial, and then ultimately get enough of those together to make a systematic review or a meta-analysis, et cetera, et cetera.
so can I just throw in, I just think that our work doesn't lend itself to the same, to that model. A purely science-based model works great for an antibiotic with a proven infection, you know, a simple cause effect thing. And what we deal with, and I think what you do a great job with, Philip, is saying there are multiple factors at play here. And for each patient, it's an N equals one, you know, and McGill talks about that as well. You have to what are the details? What makes a difference to this particular person? And Stu McGill has a whole thing about how physical therapists have dumbed themselves down by strictly working with stuff that has science, but then you end up with a dumbed down, oversimplified version that doesn't necessarily help people the way it should. So anyway, I don't want to go to a true believer model, but I really think looking at it, and you've done a great job with looking at, you know, what level is the problem coming from, and who is this person, and, you know, can we really individualize care? And that's one of the great. It's probably why I'm still working 43 years later. Is that so much fun to figure that stuff out with a person, you know? So
Yeah, yeah, yeah. I agree with you there. There was a point, as many of you know, I worked with Craig Levinson for 4 or 5 years and helping him with his coursework. And there's a point there I was really trying to push us to in that work to incorporate the rehab approaches that were first and foremost in his work with the some sort of manual therapy and trying to figure out a way to put all of this together. And as I've mentioned before on here, he wasn't all that keen to do that. Felt like that pathway had been already walked, and you know, to a degree, I think he was right. And you know, just different perspectives on the same problem, I suspect. But I mean, the when I remember thinking about the fix your own back stuff when I first started putting that together, which in retrospect is really the neurocentric approach leveraged towards the disc injured lumbar spine. And the historically, the way that when I first started playing with it, I felt really self-conscious about it because I was really kind of pushing back a bit on that n equals 1 kind of drumbeat that was coming from Stu and coming from Craig. And both of those guys were really important from a formative perspective in my career, from my exposure to both of them. But I couldn't get over the fact that it seemed like of the disc injured patients that I was seeing, they weren't all the same, but they probably 70% of them could fit into a flow algorithm that would predictably make them better. And that's not an N of 1, but it does take 70% of one of the biggest problems out there in physical medicine. I won't say take it off of the table, but it sure as hell approaches it or addresses it, I think, better than most of the current options that are out there in many clinics. So yeah, I think you mentioned the limitations of a reductionistic science model, which is a legitimate concern. You know, we have in our scientific research model that we use, we try to control our variables by parsing things down to smaller and smaller and smaller elements. But at some point, we have to realize that we're dealing with a systems-based problem. And you can take a system and look at all of the various inputs and outputs, and you can get very reductionistic on one input and one output, define your variables there. But then when you apply that and it's absent the other inputs or and or outputs that are covariables, it gets to be much more difficult to we start to run into the limitations of that particular kind of scientific model. And intent to treat research models seem to be a little bit of a better way for us to go in study design on that, I think, because it takes into account the clinician's ability to act on the fly for that N of 1. And those papers, I think, are a little more interesting. I know that those, when we were one of the clinical sites for that NIH paper, it's the largest federally funded studies for low back pain and neck pain for chiropractic manipulation for both of those conditions. And our clinic was one of the treatment sites for that. There was, beyond the manipulation, we also had intent to treat green light to perform other things as well. But we had a pretty consistent and relatively small list of things that we could do. I recall being in that study, having so many of those patients that I was working with from the study where we were only supposed to apply the manipulation in the treatment cohort. I remember thinking many times, like, God, if I could just give this person some exercises to do, they would get a lot better. And or if I could just do a little bit of extra manual therapy in this particular area on these particular structures, that person would probably get a lot better. And then it was funny because, you know, a lot of those patients, I couldn't pollute that. I just had to smile and nod. I can't tell that patient, yeah, I really wish I could do this. But after the study was over, I mean, that was a 5-year study. but each patient only went through for 12 weeks. And then they had follow-up for a year. But I had a pretty sizable handful of those patients that after they'd finished their 1 year follow-up for the study, they would come back in and seek care to help out with their back pain. And then often for those that we had just been manipulating and getting symptomatic relief, adding a little more manual therapy and some functional exercise training, we often were able to get those patients on the other side of their chronic condition. Let's see. I see a few friendly names over here. Hello, Dan Trong, Brad Farah, Pally Cooper. It's nice to see you here. Thanks for joining us. I hope you're well. That's about all the cases I've got for today. Does anybody have any questions? To touch base or to enforce what we were saying earlier, remember the NCA Online Academy is occasionally available as a lifetime offer, and the cost for that steadily increases. It's $100 higher now than it was, 16 weeks ago when we launched this thing. In 2 days, it'll be $100 more than that. For the online academy, it will give you 35 hours of continuing education that is accredited by PACE, for those of you chiros out there that are in states that allow that. 35 hours of online continuing education. You also get $100 off of future in-person courses that I teach in NeuroCentric approach. We currently have one of those scheduled on the books. The lower quarter 12-hour course is going to be in Seattle on February 10th and 11th. You can go on to the NeuroCentricApproach.com website and find links to that if you want to sign up for that course. Since Brad is on here as well, Brad and I are talking about the possibility also of doing a Portland upper quarter course, probably before May, I think it was, Brad, that you had requested. So we might be able to pull a lower quarter course off in Seattle and then an upper quarter course a month or 6 weeks later in Portland. That's what's generally shaking out here, because I'm going to be gone for much of June, traveling with my wife and my son when he gets out of school. So please do join us. Those of you on Facebook, there is a link handily placed there on the where you are watching, where you can go directly to the online academy and sign up there. If you go to the NeuroCentric Approach site, you can find the links to the in-person courses. Actually, I think they're on the online academy site as well. Okay, so if there are no questions, last chance, guys. I will bid you adieu and a very happy new year. You guys be safe out there. Use Uber, use Lyft, use your public transit systems. Don't be stupid and drink and drive, all right? And in the meantime, going into the next year, please stay curious, stay compassionate, and let's go help some people. You guys be well.